Welcome, everyone, to the beginning of a new century. No, I haven't got stuck in some sort of time warp. I know that it is 2022, but this is episode 101 in the Royal Society of Medicine's COVID-19 series. In the previous 100 sessions, we've heard from leading experts from a broad range of disciplines who have been helping us to keep pace with the changing body of evidence on SARS-CoV-2. Its consequences, both direct and indirect, and the responses to it. This has been a remarkable achievement, and I want to pay tribute in particular to Simon and Roger, but also to all of those who have been behind the scenes in making it happen. At the same time, I think I speak for us all in saying that I hope that we don't have to keep going for another 100 sessions. But unfortunately, the reality is that throughout this pandemic, we remain at the mercy of what we know is a rapidly mutating virus that always seems to be at least one step ahead of us. However, we have learned an enormous amount, gaining knowledge that will be invaluable in the face of future health threats. And the challenge will be to make sure that we don't forget this. Now, this isn't the first time that I've participated in this series, but it's in a new role, asking the questions rather than answering them. And I'm really not sure which is the easiest, but I'm really fortunate to have as our guest today someone who is able to bring a particularly valuable perspective to this topic. Hans Kluge is the Regional Director for Europe of the World Health Organization. He was born in Belgium, where he qualified in medicine, but he has worked all over the world in some of the most challenging situations. And given his experience, if anyone was in the right place at the right time during this pandemic, it was Hans, but that's his story to tell. So Hans, let me begin by welcoming you to this Royal Society of Medicine webinar and by thanking you for agreeing to join us. Maybe I can start by asking you a little bit about the post that you occupy. I've said that you're the Regional Director in WHO for Europe. I suspect that when many people hear the term WHO, they think of the headquarters in Geneva. But a huge amount of work takes place in the regional offices. So I wonder if you could say a bit about the structure of WHO, and in particular, where the regions are and what the regional offices do. And maybe then say something about your region. I'm speaking to you from the United Kingdom, a country where our understanding of the word Europe is often somewhat less than we might hope for. And indeed, for some people, they talk about going to Paris or Frankfurt as going to Europe, as if this island was in some other part of the world. So can you take us through the geography of the region that you're responsible for and how it relates to the larger organization?
Thank you so much, dear Martin, and colleagues from the Royal Society for having me here. It's very exciting. So the WHO is what we call a federated organization. It's a specialized agency of the United Nations with the mandate to coordinate international health. For some people, indeed, it's true, but it's a bit confusing. But I always say, for a Belgian, where we have 7 ministers of health, the structure of WHO is quite straightforward. So we have a headquarter in Geneva, globally, norms and standards, and then we have 6 regional offices. For example, I was working previously in the Southeast Asian region with a headquarter for the region in New Delhi in India. Now I'm the region director, as you were telling, dear Martin, of the WHO European region with its regional headquarters in Copenhagen, Denmark. And then the third level are 150 country offices. And it makes a strength of the organization, because if a certain level does not have the expertise, it's a phenomenal network. And for, let's say, my region, it goes from Lisbon, from London, down to Vladivostok, Central Asia, Turkey, Israel, the Caucasus.
Great, thanks. So that's really quite challenging. And of course, you border with a number of the other regional offices, the regions as well. Of course, you've got the Mediterranean, you've got the Arctic, where you border with the Pan American Health Organization. So maybe you could say something about how you interact with the other regions. I think you were in Qatar recently, where you had a meeting with your fellow regional directors. And how does that, do you work with each other or do you work through the center?
Right, we have what we call the GPG, Global Policy Group. It's basically the collective leadership of the World Health Organization, consisting of the 7 politically elected officials. It means the WHO Director General, Dr. Tedros, quite well known, plus his 6 regional directors. And you're right, recently you were in Qatar, in Doha, for actually the first in-person retreat of the collective leadership since the pandemic. So we come together once every 2 weeks virtually, or every 6 months now in person. But I strongly believe that inter-regional collaboration is the future of WHO. And this has been, in fact, highlighted by the pandemic, that we have similar challenges, similar solutions. For example, now we are developing a tripartite memorandum of understanding between the WHO European Office, my office, PAHO, which is the Pan American Health Organization, with Dr. Carissa Etienne, and HHS with figures like Dr. Fauci, that we see we can learn a lot from each other. Similarly, very close collaboration with the West Pacific, Dr. Takeshi, who invited me in February to go to China, Japan, South Korea to work together on digital health. So this cross-fertilization is very important, because ultimately, Martin, what I saw is that the pandemic has been nowhere globally. Everywhere the pandemic was locally. So we need to adapt the global narrative to the region specifics, but fertilize each other's knowledge and exchange.
And of course, it gets complicated because the regions are to some extent defined historically. So we have, even if you look across North Africa, some of the countries are in the Eastern Mediterranean region of WHO. Some of the countries are in the African region, even though they're beside each other, like Algeria and Morocco, for example. You've got to deal with them. And as you say, you cover the Central Asian republics, who clearly have strong trading and other links with China, which is part of the Western Pacific region. So there's it's a really complex set of relationships, even though you might think it, people might think it's simple, but I think you've captured the challenges that are there. Now, I wonder if I could just take you back to the introduction. I said that you'd worked in many challenging situations, and it would be really interesting to hear how those experiences have helped you to prepare for the job that you're doing now in Euro, and particularly in the pandemic.
Yes. So it was very difficult, Martin, to prepare for the job, because very few people have been in this job and are still alive also. So, for example, I was criticized during my campaign, and you have been following this very closely, Martin, right? That, and Hans Kluge, technically very strong, but politically, he has very few political experience. So the point I want to make is, and I try to convey this to my 2 teenage daughters as well, that try to pick up from every experience something. For example, I was working, as you know, with Doctors Without Borders, Médecins Sans Frontières, in the most challenging circumstances on earth, under the military dictator in Burma, Myanmar, North Korea, 2 years in the former gulags in Siberia. I never could think, Martin, that very operational experience on the field would serve me so well as a regional director who first and foremost had to deal with norms and guidelines once the pandemic broke out, and now with the war in Ukraine. So what WHO needs to become, and that's the internal reform I'm doing, is to become an agile organization. You need to issue norms, guidelines, standards, but if people are being left behind, we have to be operational as well. It was WHO and not any NGO who, as the first, went to the migrant camp in Belarus, when I got the permission of Alexander Lukashenko to go there, remember it was a hot period in the migrant camps between Belarus and Poland, we got the permission, we went there, we put the supplies in place, the showers for the mothers and the children who had not had a shower for 3 weeks. So, and that, I owe a lot to that experience. The same, my previous function as Director of Health Systems, where I was working closely with the European Observatory on Health Systems and Policies, of which you are the respected co-director, it gave me the insights how important it is for WHO to work with academics, with universities, because WHO should never lose its scientific edge.
So on that, it really raises questions about how we get the next generation, you know, the Hans Kluge in 30 years' time, questions of how we develop our health, our professionals into this work in international health. And it's something that I've been very concerned about, because obviously a lot of our graduates do go on to work in international health. I get a lot of people asking us. So I think what you're saying, or maybe you could help me, you're saying the frontline experience is really, really important, but also the links to academia. And it's quite challenging to think of a training program that will bring all of that together.
Yes, absolutely, Mark. I established as one of my campaign commitments the European Leadership Academy, because I was the only candidate of the 6 who went to all 53 countries in 4 months. It was the biggest marathon of my life. And I asked every Minister of Health, every Minister of Foreign Affairs, what do you think WHO has right? What have we messed up and should we do better? And several countries were telling that WHO doesn't grasp enough how an administration works. How can we be useful? Instead of giving theoretical norms, give something actionable. And that's why I decided to have the European Leadership Academy, inviting junior and mid-level cadre to our office, give them formal training, and then put them out for 6 months in our country offices or some of our WHO Center of Excellence, like in Barcelona, on health financing. I strongly believe, and I had the fortune to have a strong academic education at the Catholic University of Louvain, then the Institute of Tropical Medicine, good collaboration with the London School of Hygiene and Tropical Medicine, and then the field experience. So if someone comes, a junior, and says, oh, regional director, how can I come and work with WHO? My first question, how many years of field experience do you have? It is the best school in life.
Great, thanks. So let me take you back to the first days of the pandemic. And you remember at the time we were hearing accounts of a new respiratory disease in Wuhan in China. Now, we'd had the experiences of SARS 17 years earlier. And at that time, some people had argued that the international community responded far too slowly. So WHO declared COVID a public health emergency of international concern on the 30th of January. But after that, it seemed to many people that relatively little happened. You know, a declaration was issued, but what then follows from that? I wonder if you could describe your thoughts at that time, take your mind back to that time. When did you think that this was going to be really serious? And what was it that made you reach that conclusion?
Almost immediately, because there was a very famous professor from the London School of Hygiene and Tropical Medicine, Professor Martin McKee, who is out to me around Christmas and who told, watch it. Remember, my experience is, if you have a nose for something, you better alert. But seriously,
yeah,
we all underestimated. I mean, including in WHO, it was only when we saw the lethal impact at the global pandemic level that the recognition was there. But we also had to remember, we had a very strong WHO country director in Beijing in China, Dr. Golden Galea, who actually did what had to be done. But stepping a little bit back, I think there were 2 issues for this pandemic. One is the alert system. So there has to be in every country an early warning system. But as you say, even when the alert was there, the political reaction was far too slow. And that's what hopefully the International Pandemic Treaty will deal with. But a global response in a geopolitical and epidemiological different world will always be a challenge. And that's exactly why from the beginning, I took a regional perspective, because the regions are close to the countries. We know what's happening over there. And we got it wrong in a number of instances, but we were also avant-garde compared to WHO globally in a number of fields. Number one, as you know, Martin, the masks, we were the first one because we knew airborne transmission was an issue. We discussed this and we took it very serious. The schools, we were the only one who had a platform to bring Minister of Education and Health together, co-chaired with the Minister of Health of Italy, Roberto Speranza. The boosters, there was a lot to tell. From the beginning, we thought boosters are important, but it doesn't mean that we should not display international solidarity. So this regionalism was very important, but definitely I also admit, I think we were all caught by surprise, Martin.
So just right back at that very early stage, we know about the very diverse nature of the European region, going from, as you say, countries like Germany and France to Kyrgyzstan or Tajikistan. We saw this variation, this diversity very clearly in the first wave of the pandemic. So many of the countries in Western Europe were hit very hard. Now, of course, partly that was because of the nature of the travel, and you had travel through people in the textile industry going from China to Northern Italy, for example. But the countries in Central and Eastern Europe that we might have expected to have been particularly vulnerable because, you know, they've got less resources and so on, they came out of it relatively unscathed. Hungary, Czech Republic and Poland and so on. And then, of course, that changed. That changed about June, July, whenever things started to be more problematic. And now they've, in total, over the whole pandemic, done much worse. So I just wondered if you had any reflections on why you think we had this diverse pattern within the region. What did the Central European countries get right in the first month? And then why did they seem to get it wrong after that?
Yes. That's a very nuanced question. If I look from a pan-European perspective, which I always try to do, I would say we have more than 2 million people who died in about 24 months. So all countries were hit. But you're right. You're right, Mark. We saw a west-east tidal wave throughout. I think that the future will tell us, but definitely, I think you mentioned yourself, Western Europe is globally very, very interconnected, but ultimately all the countries were hit, and ultimately we saw the vulnerabilities in the health systems, particularly in the eastern part of the region, patterns of transmission, reporting. This is also an important one, right? Because there's a lot to do about the mortality, the reporting strategies, the testing capacities. If you test a lot, you report a lot, of course, you'll have more cases, the hospital capacities. So it comes back that we have a lot of inequities in the region, but ultimately all the countries were hit. And I think that we will need a little bit more of research to really know what was happening. But then again, we saw in Western Europe as well, some countries like the Netherlands who were much better, doing much better in the first wave, then the second, third one, they got hit. So ultimately, no country health system was prepared, and we have to do better for the future.
And this is the challenge, isn't it? Because if we look at the pandemic as a whole, you know, you can look at the total cumulative excess mortality or whatever, but we almost need to break it up into different waves and look at how countries did at particular times. As you say, in Western Europe, there were major problems at the beginning, but the countries were much more connected both to the rest of the world as travel hubs and to each other. Whereas in Eastern Europe, they closed down very, very quickly. But then once testing capacity became available, then that was more concentrated in the West. And I suppose we've seen that elsewhere with countries that have done well initially, like Korea, and Taiwan, for example, now having problems later on. So it's really quite challenging to make sense out of all of this. Let me stay with the Western European situation. So here we have in Western Europe 27 countries in the European Union that have chosen to harmonize many of their policies, and their ministers are meeting together all the time to coordinate their work. And yet, when the pandemic struck, the responses were really characterized by a lot of fragmentation. People were closing borders. There were many examples of neighboring countries adopting different policies. The Netherlands, Belgium, for example, in the Nordic countries between Sweden and its neighbors, and so on. There was mutual support, but it was relatively limited. Now, we know that the responsibilities for health in these countries are complex, and they involve national authorities. They've got the European level, and in countries like Germany and Spain and Italy, they've got the regional authorities. But in this region, and this is about half of your region, you've got 53 countries here over 27. Both you and the European Union have important roles to play. And I just wonder if you could help us to understand what we can learn from those early experiences of the working together with your counterparts like Stella Kyriakides and Ursula von der Leyen and so on, and tell us how the WHO and the European Union work together, and maybe whether there are lessons that could be learned.
Yes. I think we were reminded, dear Martin, that we're still living in a Westphalian world where the national interest and sovereignty dominate the international solidarity, and health is no exception over there. I myself have been trying to take a pragmatic approach, because there was a lot to tell when, for example, there was this EU joint procurement, which I think was a silver lining in the pandemic. But then globally, countries were telling, or continents, look, the EU is doing joint procurement. What about the other countries and the middle and the low income? But we have to be realistically, politicians are elected by their people. So it's their duty to take care of their people. I discussed this actually quite early on with Dr. Anthony Fauci, and we have a similar approach with do it all approach. You have to take care of your people. At the same time, nothing should prevent you to share with the lower and middle income countries. Do it all approach. Actually, I was in the office of Stella Kyriakides the day before the pandemic started. I remember very well because it was the first and the last time since long that we met physically. And this collaboration has been very smooth, but they were also struggling with the same kind of issues that also the EU had a challenge to put the 27 countries into the same direction. So the lessons learned, I think, is that the international health regulations had a bit of a weakness, that you cannot, this has to do with criticism on WHO. WHO was criticized a lot, and why didn't tell the country to do this or that? We can tell. But WHO is only as strong as the teeth given by the member states. So unless there are provisions in an international legally binding agreement for non-adherence to the provisions, there is few which can be done. What helps sometimes is peer pressure. And that's why we work more and more on a sub-regional approach. When you put a number of similar countries together, sub-regionally, and you exchange. And final point maybe on this one is that we need to revise the list of criteria on preparedness for pandemics, because there is such a benchmarking, and you were also involved, I know, Martin, also with the National Security Council in the United States, right? That according to our lists, there were countries which were top ranked on being best prepared. And then their health system collapsed during the pandemic. One of the reasons, because it did not include governance aspects. To put it simple, if you have very strong public health people who are giving the right advice, but the politicians don't take the advice and do something completely against the evidence, then you can have a strong public health system, but it's not going to work. The issue of the masks being one of them. So we have not cracked that nut, but that's why I established more than a year ago the Pan-European Commission on Health and Sustainable Development to rethink policy priorities in the light of pandemics. And I want to acknowledge here you as the chair of the scientific board. That's what we did, right? With Professor Mario Monti, previous Prime Minister, Minister of Finance of Italy, previous EU Commissioner, to have a commission with commissioners, particularly outside the health sphere.
So let me come back to that in a minute, Hans, if I may, because I just, while we're on this point of the relations with the European Union, one of the challenges is, of course, you've got not just WHO, European Union, but also the the EU specialized agency, the European Centre for Disease Prevention and Control. Now, of course, you do work together in areas like tuberculosis and so on. So could you maybe say something about how that set of relationships works?
Yes, so there is the so-called Health Security Council, where WHO has an observer status. When the ECDC is convening its meeting with the 27 focal points, I myself, I have a monthly or 2 monthly meeting with the Commissioner Stella Kyriakidis, or ad hoc. Same for the Director General, Ms. Sandra Galina, and the same relationship between my directors and the unit heads. So there is structured collaboration, but ultimately we know how it is. It depends a lot on the individuals. And I must say that this has been working very, very smooth. The same with the EU ambassadors at the country level, because WHO's mandate is health and well-being based on the values of universality, solidarity, equity. While we have to acknowledge this, the European Commission, the European Union is a first and foremost economic body. And there you can have tensions between providing the right, for example, on border closure or such issues. There's always a bit of tension between what are the economic interests and the interest on population health, which we don't have. So in that sense, we can be very helpful to the European Commission, and the European Commission with its legal and financial power can be very helpful to the WHO. And that's one of the pillars of the European Programme of Work, which is my vision of health endorsed by the 53 member states, the power of positive partnership.
Maybe say a bit more, could you maybe tell us a bit more about the European Programme of Work? Because of course that was written before the pandemic, and the pandemic has obviously changed so much. So what elements of your vision there are particularly important as we go forward?
Yes, I was mentioning that I did a campaign tour, a campaign marathon across the 50 countries, and that gave me such a knowledge to shape the vision for health and well-being in our diverse region. And it's based on the political premise of what do the citizens legitimately expect from the health authorities, because we see an erosion of trust into public governance, including health governance in many countries, which is very worrying. It has 2 goals. One is leaving no one behind. We strongly believe in this. And the second one is empowering the national health leadership, because we see that in many governments, the health minister is a bit seen as a minister who doesn't produce economically, who only costs money. And that's something that we have to change. And then the number of priorities, but maybe to point out the flagship ones, which is mental health. Even before the pandemic, mental health was a flagship, now even more. Digital health, the same. Behavioral insights, the same, and immunization. Basically, the pandemic tested the European Programme of Work. And I must say that it came out as very relevant. Also the modus operandi to work much more sub-regional, because you have 53 countries. You have from the UK to Turkmenistan. So it's very helpful to work sub-regional. During the pandemic, every 2 weeks, I had video conferences with the Minister of Health of sub-regional groupings, be it the Nordics, Central Asia, the Visegrad, etc.
Yeah, the Visegrad countries, just for people who are not familiar, are the Czech Republic, Slovakia, Poland, and Hungary, the V4. So one of the key issues that's emerged from the pandemic is the importance of public health communication, which is, of course, what these webinars are about to some extent. And we've had our Chief Medical Officer, Chief Scientific Advisor becoming public figures. And in a number of countries, thinking of Ashley Bloomfield in New Zealand and elsewhere, where these people are becoming almost, they're developing a following in their own right now. Now, I think it's fair to say that during the pandemic, you've achieved a much higher media profile than any of your predecessors, and I've worked with at least 4 of them over the years. And of course, that in part reflects the sheer scale of the pandemic, but also the increasing opportunities to communicate through social media, where you are very active. Many health professionals, and including, I suspect, many watching us today, find this a rather difficult area. So I just wondered if you could share any insights that you have gained through this experience, through your regular media briefings, your engagement in social media and so on. Any tips that you can offer for our viewers on things to do, or maybe as importantly, things not to do?
Yes, I learned this from Toyota. When Toyota did a big reform, like I'm trying to do, they cut on many divisions except communication. And I always remember this. Communication in life, be it the pandemic, on health issues, in the family, is key. So I put up training programs for all my staff here. Great scientists, but as you say, dear Martin, not necessarily the best communicators. So you have to be courageous because you put yourself up front, but quick. And I think that's, again, maybe the MSF experience, that from the beginning, I understood there's a need for a voice which is calm, which conveys the science, which does not panic, and which is transparent. But of course, I do not want to underestimate the complexity, because at one point, everyone at least one time will get it wrong. So what's important is that you are transparent. I mean, the country I'm sitting in, Denmark, for example, has done this brilliantly. It was the same Director General, Dr. Søren Brøstrøm, who consistently communicated to the Danish public, who was telling when they didn't know anything. For example, I remember very well the moment with AstraZeneca and there were some side effects. They were communicating what they knew, what they didn't know, and then updating the science. And the politicians tried to stay away. And the other point is that I see the social media as a equalizing platform. It's important that WHO puts out the information, but I also use it as a listening platform. What is going on? So that you listen to the people. That's very important.
Okay, thanks. And just at this point, I might just interject to say to those who are watching that to remind you that you can put questions into the Q&A, and we will be coming to those in a few minutes. So I would encourage you to put more questions in, and particularly questions that relate to Hans's role. Obviously, we can't answer questions about individual conditions and patients and things like that. But we will get to that in a minute. So just on a related topic about communication, we've not just had a pandemic, but we've had an infodemic, and we've had to deal with a tsunami of disinformation, some from the usual suspects of people who reject any idea of collective action for public health, but also, sadly, in this country and elsewhere, from a few of our professional colleagues who have taken a rather contrarian perspective. And I'm thinking here particularly of the proponents of herd immunity that were influential here and in a number of countries. Now, we know that if you just simply correct their mistakes, particularly where people have an ideological background to it, somebody coming out from WHO and saying, well, that's wrong. And they'll say, well, of course you would say that. I mean, WHO works with the Gates Foundation, and we know that Bill Gates is trying to track everybody in the world by injecting microchips and all the usual things. I should add for clarification, these are views expressed by others, and they are absolutely not true, in case somebody clips this bit out of context. But I'm just wondering if you have any advice as to how we respond to this sort of thing whenever you get often palpable nonsense, but things that may seem to us nonsense, but actually are quite convincing to people who are willing to believe them.
Yes, number of points. First and foremost, to take it serious, because sometimes it can look like a complete nonsense, but for people, and there can be influencers, it can be religious people in the rural area who convey this. So first thing is to regularly communicate through all popular platforms to convey in a understandable language the science. I think that's important. Number two, we learned a lot, Martin, to work with influencers to convey certain messages, for example, on the importance of vaccination, and then to adapt to a whole range of platforms where people can, you guide them to the right information. But of course, there will always be a politicizing some of the messages, and we have to be aware of those. We cannot eradicate those, but we have to be very, very consistent, very feverish in conveying, and I believe in not blaming, because a natural reaction is to laugh away or point out the finger. We have to try to engage with those communities. And what I learned is that if you engage, people often have legitimate questions. For example, often people don't understand, how can you have a vaccine in 1 year which works and which is safe, while people know it takes 5 to 10 years usually to develop such a safe and effective vaccine. So then we have to explain that those vaccines also underwent the usual emergency use listing procedures. So communication is a never-ending story, Martin.
And that's fine to some extent, but I'm just wondering about a situation where we see some groups ideologically driven who are simultaneously promoting pro and anti-vaccine messages, or as we see in the United States, pro Black Lives Matter, pro Ku Klux Klan messages, because what they're trying to do is to create divisions in society. They're not interested in the health issues. It's just they know that health messages communicate rapidly. If you put out a health-related tweet, often it will spread more than a tweet on something else, and particularly where it does to appeal to conspiracy theorists. So there are people who are either using this messaging for their own, to undermine the belief in democratic political institutions, or they're using it for clickbait to monetize their messaging or to spread malware. So we've got a number of motivations here. I'm just wondering how we deal with them, because they're particularly difficult. It's not a matter of just explaining.
This is absolutely true. So this is together with WHO globally, concluded agreements with Twitter, with Facebook, with Google, so that there is a, let's say, kind of a screening process, of course, respecting the freedom of individual opinions, but also that if people Google, for example, that automatically the science-based information comes up first. And ultimately, if it's too much or really damaging, then of course the country has to step in with some regulatory mechanisms.
So it is really challenging, isn't it? So I want to take you back to something that you've alluded to in a number of your responses. And, as we've said, and we've seen through the webinars, in the 100 webinars we've had, our knowledge of this virus has really evolved rapidly. And one of the things that, as I say, we know much more clearly is that COVID is spread in an airborne manner. And headquarters, as you noted, has come under quite a bit of criticism for the delay in acknowledging this fact. Now, your work on TB in Russia, in particular in Russian prisons, in the Gulag, has really given you an understanding of the nature of airborne transmission. And you're a Belgian. And the Belgian government has been placing a very high priority on indoor air quality as a means to reduce the transmission of all airborne respiratory viruses with HEPA filters and CO2 monitors, and is clearly seeing that as an important strategy in moving ahead. But then we look elsewhere, and we've seen the White House Correspondents' Dinner the other day, which had a CO2 level of over 2,000, for example. And as we now know, Antony Blinken and a number of others have got COVID as following that, despite everybody being tested and vaccinated. So I just wonder if you think in across Europe, we've really taken on board the full implications of airborne transmission, not just for SARS-CoV-2, but for other respiratory vaccines? And do we need to do more going forward to improve indoor air quality, the way we dealt with water quality in the 19th century?
Absolutely. It's one of what I call the 5 pandemic stabilizers, which came out of our high-level expert group, chaired by Professor Antoine Flahaut. This is in contrast somehow with the concept of waterborne, vector-borne transmission is much more accepted. I think with the very fast spread of Omicron, there has been a change. I think the key issue here is that in general, self-protection measures like masking, distancing, self-testing has to undergo a paradigm shift from self-protection for COVID-19 towards more being part and parcel of 21st century health protection behaviors. And that, for example, the people in Asia, like in China, have learned already the lesson very practically and pragmatically. If there will be another wave, that the people don't wait so long to wear a mask, to have the rooms much better ventilated. So absolutely, I think this has to be decoupled from COVID-19 and become more part of our health-seeking behaviors, Martin.
And earlier you were moving into the issue of the looking beyond the pandemic to the Monti Commission. As you say, you convened a group of people who were not the usual suspects. They were former heads of government, former presidents, former prime ministers, people from central banks and so on. And I just wondered if you could reflect on that process of engaging outside our usual health silo, what the value of that was and how we're going to move forward with it.
I tried something similar during the economic crisis. When health suffered a lot, we saw suicides increasing, and you and your team contributed a lot, right, to that one, the impact of the economic crisis on health and health systems. But I failed. We had a meeting in Oslo with Minister of Health and Finance, and maybe we had 2 Ministers of Finance from the 15 countries. So this time I saw my chance and I tried to be a little bit more smarter. I say I need to have a non-health person chairing the commission, this independent commission. And I remember very well, I had to convince 3 Sundays Professor Monti that I didn't dial him by mistake. He thought I dialed the wrong number. He says, I have no clue about health, Dr. Kluge. I say, Professor Monti, that's exactly why I need you. Because Professor Monti, when he was saving, I mean, really heroically, the euro and Italy, had to cut a lot in the health system budget. So now, if he goes with us and together with a number of other non-health commissioners to heads of state and heads of government and tell what's happening with the pandemic is nothing else than the health sector taking the other sectors hostage because of chronic underinvestment in health workforce and health systems. That is a very, very big leverage that we have. So in a nutshell, the whole aim is that once that the pandemic finishes, the heads of government do not go into a cycle of neglect and forget about investing in health and health systems. I always say health is not everything, but without health, there is nothing.
Thanks. And I would encourage people to look at the Monti report.
Yes.
You just
Yes.
Google it and they'll find it on the WHO website. I'm going to move to questions in a minute, but just one last point. You've recently been in Ukraine. You're going back to Kyiv and perhaps Kharkiv in the next week or so. So I just wondered if you could say something about the situation there and the challenges it poses, obviously more widely, but particularly for COVID, because of course there was quite a lot of that in Ukraine before the Russian invasion.
Yes, actually, I was in Kiev in January before the war started, and there were about 2,000 severe COVID-19 patients on oxygen. And then you may remember, dear Martin, that Dr. Tedros and me issued a press statement on the acute shortage of oxygen. And then, of course, reporting systems fell down. And people are preoccupied basically that there is a population of 40 million of people who need shelter, need to be taken care of, millions of people leaving the country. So there is really a kind of a gradation of priorities, but I am very concerned, yes, about COVID-19, but not only COVID-19. Actually, there are 3 competing emergencies in Ukraine. 2 of them I discussed with the Prime Minister and the Minister of Health in January. One, the COVID-19, because only 1 out of 3 Ukrainian people were vaccinated. The second, poliomyelitis. I mean, the whole discussion we had that time was that we needed mass vaccination of all children on polio, because the region as a whole can lose the polio-free certificate. And now third is the war. So it's a humanitarian catastrophe. So I decided for myself that 75% of my time will be dedicated to Ukraine, and very genuinely, I want to thank every single individual participating here at the webinar for your support, your solidarity, be it a prayer, be it sending some supplies. I mean, we need solidarity with the Ukrainian people.
Great, thank you, Hans. So I'm now going to move to the questions, and we've got a lot of them, and they're very varied. But I'm going to ask you one from Roger Kirby, who would normally be sitting in this chair, which is your opinion of the current Chinese government's policy of zero COVID, which seems out of step with the response elsewhere. Could you, and I know that you've been asked about this, certainly on, I think on BBC Hard Talk, you got quite a lot of pressure on this a while back. So any further reflections on that?
You remind me of the Hard Talk, Martin. They were telling me you're working for the World China Organization, which I thought was very unfair, honestly. But you know, on the seriously on the zero COVID strategy. Well, of course, China has been doing very well in for a long time on the containment, but that's a bit one of the outcomes of the Monti report, that it's a balance between lives and livelihoods. So it's a fine line between protecting the health of the population on one side and keeping your society and your economy running. And what I'm particularly concerned is the mental health. How much the people can take, no, really, I mean, they're tired of the pandemic if they're isolated too long. So in that sense, if a country decides to lock down, they really have to pay attention to the microeconomic needs, to the vulnerable people. We have left many people behind also in our region, like in the elderly homes in the first wave, and on the mental health. So this is very important, and ultimately it's a balance.
Yeah, and that has been a challenge for many countries. Now, yes. I'm going to come to a question from Carmen Power, and it's a question that I know if Simon Wesley was in the chair here, he would ask, because he asks me every time when I'm sitting in your chair, and that is, did Sweden get it right, especially in relation to unbroken education for children and the population, and its population's mental health and economic stability?
So as a principle, WHO does not point out any particular countries, but of course this question has been asked to me time and again. I mean, we can look at the figures, right? I mean, the numbers were much more far above the Nordic average. On the medium and long-term consequences, this is the jury is still out on that one. Another point is that it's not that Sweden didn't implement any restrictions, no. I mean, they were not that strict like other countries, but they did implement physical distancing and a whole number of restrictions. But it's true that the response was not unlike the other countries, and we know what had to be done. I mean, masks can save a lot of lives, and it is cheap and effective. The same for distancing. But of course, yes, the mental health impact in countries with a very strict lockdown has to be looked at. So the jury is still out, but there are a number of objective indicators which everyone can compare.
So I'm looking at the questions and I see people's full names and I'm making assumptions about who they are. So I see John Anthony Jewell, which I think is Tony Jewell, who asks, given the range of countries and blocks in the WHO European region, how have the relations with, well, it's really with the Russian Federation. I know you don't want to go into the countries, but obviously there are going to be consequences of the fragmentation of Europe and the difficulty with countries not being at the table and so on. Can you say a little bit about that? And I don't want to push you too far because I realize that it's a diplomatically sensitive issue.
Yes, I'm very, very concerned about this. I mean, the whole motto of the European Programme of Work is United Action for Better Health. And that's, remember, I was going around the whole region during the campaign to bring East and West together. So, of course, this is fractured now. Actually, there are 38 member states which have asked me to convene an emergency regional committee of all 50 ministers of health. And it will happen next week, Tuesday and Wednesday, which is very stressful, but according to the constitution, I have to do this and we will do it and we'll see what comes out. So yes, I'm very, very concerned. So what I always say is health is not politically. We need health for all. And we are monitoring the impact of the war in Ukraine on Eastern Europe and also of the sanctions. So any bilateral collaboration, I believe, should continue, but I'm always very vocal on attacks on healthcare facilities. I mean, attacks on healthcare facilities are a breach of international humanitarian law on healthcare workers as well, and we desperately need humanitarian supplies to Mariupol, to the Donbass. This is something that we're working on very, very hard. The principle is to leave no one behind, and I have been working, I told you, to North Korea and Myanmar. Yeah. And sanctions have to be very, very smart because it is easy to target innocent people.
Indeed. And question from Rachel Pugh. What's your view of the winter ahead? Are you preparing for a winter with new COVID outbreaks and new variants?
Yes, absolutely. I call it a false strategy. With so many people have been infected by the Omicron due to its fast transmissibility. So for sure, the new variant is out there already, but it doesn't have to be a catastrophe if countries are doing the right things, meaning number one, protect really the vulnerable people. When we get to the fall, first and foremost, the elderly, with people with underlying diseases. Number two, do whatever it takes to vaccinate the unvaccinated in the population and boost the vaccinated in the population. So it's not only the vulnerable, it's the population in general. Number three, strengthen the surveillance and genomic sequencing capacity in every country. The country I'm sitting in here in Denmark has a very strong capacity, so they are able to pick up any alarm in a certain community very quickly, so that they can localize the response and do not have to go to nationwide restrictions. And the fourth one is urgently for health systems to deal with the backlog of patients. In many communities, we know that cancer screening has been stopped, surgery has been postponed, and we need to know much more about long COVID. 10 to 20% of the patients, and we worked on this with the team of Professor McKee and the London School of Hygiene Tropical Medicine, still have symptoms after 12 weeks. I know young children of staff here, young people, it's very invalidating. They cannot sleep at night, they have mental health syndromes. We need to know what this long COVID means. So to tell that the COVID-19 is just like another flu is absolutely untrue.
So we've got a question from Emma Storr, who builds on that and says, do you think the experience of the pandemic will lead to improved funding and support for public health medicine within countries? And obviously the Monti Commission does have a large element of that. But she is then saying, it seems like, and I know you can't comment on the UK particularly, but it seems like in the UK, public health has been underfunded for many years, was highlighted during the pandemic. And we've just seen an announcement that the UK Health Security Agency is going to have its budget cut by 40%. Leaving aside the UK in particular, I wonder to what extent you're concerned about countries thinking the pandemic is now over and we can cut back on the increased expenditure that we had during it.
It's indeed a concern. When you have a pandemic, you usually have a cycle of panic followed by a cycle of neglect. And that's what indeed we would like the Monti Commission to work on. Actually, one of its main recommendations has been implemented already. It needs to be operationalized, but it was a G20 joint task force between Ministers of Health and Ministers of Finance, so that this collaboration is not ad hoc like during the pandemic, but rather institutionalized. But it cannot be taken for granted. Absolutely. Whenever I go to a country, be it tomorrow to Finland or last week to Armenia and Azerbaijan, I go with a copy of the Monti report to the head of government, head of state, with that mantra that we may have, well, another pandemic soon, and to implement universal health coverage based on good primary health care, which is the best prevention and for a pandemic, is peanut investment compared with the tremendous economic damage. But what it needs is political leadership and courage for a minimal upfront investments. And no doubt some countries will fail to do so, but I hope that more and more countries will have learned the lesson.
So there are a couple of questions, but in and from various people, and they relate to this issue of COVID fatigue. Whether there is, certainly some of my colleagues, Steve Riker and others, would actually argue that there is no such thing as behavioral fatigue, even though it was argued at the beginning. But there is a concern that people, now we're nearly 3 years into the pandemic, people are sort of giving up to some extent. And I just wonder what can be done to address that.
Yes, I think a lot of pragmatism. People definitely are sick and tired of the pandemic. So we need to give people a break when the epidemiological situation allows so, but not to go from full package of restrictions to a brutal lifting, because this has been a particular challenge in countries that they go from full-blown to a complete opening of the society, go in a stepwise approach and make it clear to the people what are the parameters to relax. In Belgium, for example, it's called a COVID-19 barometer, so that people don't have the impression that governments are flip-flopping, but that it's clear when some more restrictions need to be implemented and when those can be lifted. But then again, the best way is to vaccinate. If you have 90% or plus of your population vaccinated and boosted, there is a very strong immunity to be resistant to the virus.
And of course, we in this country are stuck at about 74%. We haven't really made much of an improvement in that. Well, we're getting very close to the end here. I'm going to fit in one very quick question, which is from Tim Malone, which is, how do we restore trust in the WHO by, and he says, mainly Western political leaders who seem to think they know better or wish to appeal to a more nationalist, them not us approach to global health?
Yes, my mantra has been direct country contact. So the direct contract I established during my campaign, I have been keeping this. That's very important because you listen and then you have to do a reform that you're agile so that you can really quickly and effectively and usefully reply. And in generally, I must say, be it the presidents in Bosnia and Herzegovina or the prime minister in Belgium, if they know you, you are giving targeted support, which is helpful, the trust is there. But WHO has to reform to be an agile organization, and it doesn't mean that it all has to be staff. WHO has huge networks of WHO collaborating centers. Comes back to my point in the beginning of academicians, right? Like the London schools for one or other, and every country has collaborating centers. So work with them, listen to the needs. Sometimes I think people make it too complicated. We became bad listeners. Listen to the people. Whenever I go to a country, I meet a present prime minister. Immediately I go to the primary healthcare clinic. I talk to the patients. I talk to the nurse. I talk to the doctors. Be a good listener and then be feverish on the follow-up of your commitments.
Great. Thank you, Hans. Well, it's been an incredible pleasure to have you with us today. You do have an incredibly busy schedule, and we have many really intractable problems to address, and we really appreciate you giving us the time to talk with us. Well, I hope that this has given our viewers, both here in the United Kingdom and elsewhere, a better idea of what happens in the WHO Regional Office for Europe and the incredible work that your team and you do. So this brings us to the end of the webinar, but before I close, can I just mention a forthcoming event that may be of interest, particularly to people in this audience, and it's a conference on tackling inequalities on Thursday, the 23rd of June. And as always, the details are on the RSM website. Now, these webinars are free to participate on, but if you do feel motivated to contribute to the RSM to support them, there will be something coming up in a minute which will tell you how to do that. And can I also just remind you that now that the pandemic is moving into its next phase, the RSM building in Wimpole Street has reopened and there are in-person continuing education events. So with that, can I say thank you, Hans, thank you to the team who are behind the scenes making all of this happen, and thank you to all of you for joining us in this webinar. Thank you and goodbye.
Thank you so much for having me, Mark. Goodbye.